Doug, and I'd like to certainly thank you for inviting me to Ireland with the surname Walsh. I had to get here at least once in my life before I check into that operating room in the sky. So I've been asked to speak on leadership tricks in leading surgical teams, but there are really, oops, this is on a timer here, really there are no tricks really, and as magicians don't disclose their tricks, I certainly am willing to talk about anything regarding safety. So let me tell you in 12 minutes a story that's really taken us 12 years to develop. MD Anderson is a large tertiary referral center. We have 189 surgeons, 75 anesthesiologists, about 100 nurse anesthetists, about 450 OR nurses, surgical techs, materials management. So it's a large group that we work out of, about 43 ORs. But let me first tell you a true story. This is a story of a middle-aged farmer who presented with sharp abdominal pain every time he got off of his tractor. Otherwise very healthy. He had had a past medical history of a major abdominal procedure for cancer, and it was at our institution. The pain was attributed to standard postoperative pain. So this was in 2006. And you can see that Houston, to quote Apollo 13, we had a problem. So as one of the surgical representatives on the institutional safety committee, I was asked to stand up and explain what had happened. And as a Canadian, I was fairly blunt and to the point, and I said that when you have a retained foreign object, this is a large system failure, and represented a failure at multiple levels. And unless there was a cultural change, behavioral change, leadership change, that this would continue to happen. This was basically our Boeing MAX 8 airplane. And fortunately, the leadership of the institution listened. And what did we do? Well, when in trouble, you bring in external consultants, and external consultants came in and interviewed everyone from the president down to the surgical tech processing instruments in the basement, and we came up with a new structure that we called the perioperative enterprise. Now, it was a kind of a new way of reorganizing a large institution, in which we would have an OR support team. There would be a head of what we would call the perioperative enterprise, where nursing would report directly to that head of the perioperative enterprise, and all of the support issues of an operating room, materials management, sterile processing, finance would report to that area. Obviously, there'd have to be interactions with an OR executive team, which would be the physician-in-chief, the chair of surgery of anesthesia, the CEO of the hospital, and the head of nursing. And as well, we had an OR, a resource team, which would be all of the academic surgeons and anesthesiologists who worked with it. And then it had to dovetail into the OR committee as well, which was a policy and voice that would go up to medical practice and executive committee of the hospital. So we put it all together, and this was the new structure. So I had to come up with an image that would appeal to a European audience that would show. They asked me, because I was the most vocal about safety issues, if I would head this up. So I said, well, what would be a European model? This would be an exciting opportunity can you imagine, to change behavior and culture of the institution, make people safer. You'd come to work, your surgical colleagues would thank you for all the hard work that you're doing to make it safer for their patients. The nurses would love you, and this is basically summarizes what it's like to take on a position like that for any of you that are thinking of doing this sort of leadership. So first thing you have to do is develop a combined mission and vision. So this took us an additional 6 months of sitting down with multiple groups, with anesthesiologists, surgeons, everyone who worked in the operating room, to come up with a shared mission and vision. And our mission and vision would be to have the safest perioperative environment in the world, We all had to sign off on this, the highest quality of perioperative outcomes, and we had to demonstrate our institutional core values. So I put the black and white pictures up because I enjoy black and white pictures in general, but it just shows you the diversity of the teams that you have to work with in an OR. We have 70 countries represented on staff at MD Anderson. And you can imagine, one thing that surgeons don't know, we show up and we expect everything to be available for us, but there is an army of people that have the instruments prepared, have all the materials there for us, and as we talked, we have to learn how to communicate with all of the people that we work with. So some of the visions that we came up to be the safest operating room was have timely and accurate communication. So this dovetails exactly into what we heard in the first speaker. Communication, optimizing all of our communication methods. And obviously, as the ORs have spread out, there's different ways that we can communicate. We had to strictly adhere to national and institutional safety standards. So we had a variety of processes and practices, but we had to standardize to reduce variation, especially in large practice. Each of us had to equally own the responsibility and safety for our patients in the work environment. We had to ensure that each of us was a strong link in the perioperative enterprise. So each one, from the person who processes the instrument up to the surgeon at the table, we all had to feel that we were part of one strong team. We had to place paramount importance on continuous education and advanced training of our employees. We realized to train a perioperative nurse takes at least an additional year after standard nursing. So we developed our own nursing training program that became highly sought after, but it would be a 12-month intense training to become a perioperative nurse. And when you put that time and effort into training people, people feel that they are now part of the team. So we spent a lot of time in this. So when we looked at outcomes, we wanted to provide unmatched surgical care for both routine and complex multidisciplinary cases. Now, our institution, about a third of the cases that we do every day are complex multi-team cases. So we've been known more for the more difficult multi-team cases. But as cancer care has moved to earlier diagnosis and smaller tumors, we also wanted to be known for routine care. So sometimes you let your guard down when you're doing the simple cases, when you're focusing on the more complex cases. We wanted to have the best outcomes that could be achieved anywhere, so that ties into developing a perioperative IT system so we can actually track what our outcomes are on a real-time basis. We had to embrace process improvement processes. So everyone who worked in the perioperative enterprise, the goal every year was to come up with a quality improvement process with aims and measured outcomes. So everybody had to participate in process improvement. We had to optimize our use of personnel and technology through accurate and timely scheduling. And as you look at ORs and multiple ORs going in different ways, you realize how important accurate scheduling is to make sure you have the right surgical team available for the cases and you have the right instruments available at the right time. We have to have a reliable, state-of-the-art, well-maintained equipment. And I'll show you one slide what it takes to bring in a new piece of equipment to an operating room environment. Elimination of waste is extremely important because the less instruments you have on your tray, the less waste, there's less counting, there's less chance that you're going to have a retained foreign object. The institutional core values are one of caring, integrity, and discovery, but the operating room is a small microcosm of a larger institution, but we wanted to make sure that the operating room also mirrored our institutional values. So we developed a perioperative code of conduct, and we came up with something that we call Code Indigo. Indigo being the kind of the purplish discoloration of a surgeon's face when they lose control and get very angry. Some of them were thinking we should call it Code Brown, but we called it Code Indigo. In a Code Indigo, if a surgeon were ever to act out, then everyone who is free in the perioperative environment is to come to that operating room and stand in the operating room until the event is closed down. We spent a lot of time in a multidisciplinary team putting this Code Indigo together. We never, once we implemented it, never had to call it Code Indigo. But we have had surgeons who have had to disappear for 6 months for some behavior modification and anchor management. There have been surgeons who've lost their start times for 3 months. So there are things that we can do within the perioperative enterprise to put a collective pressure on surgical behavior. Few surgeons, unfortunately, have to retire early. And it's usually the high-performing surgeons that are the ones that behavior has been allowed to develop over time, and that can be very difficult when we look at the overall safety of a large perioperative environment. So we have to take the responsibility for, again, assuming accurate communication. So how did this happen? How did we leave something in someone? Why did it happen? And are there any simple explanations? We put together a task force to look specifically at retained foreign objects. And this took a year of work to look at all of the layers of why we would leave a foreign body in someone. You know, simple thing is that we've got way too many instruments. This is a combined thoracic and neurosurgical case, and you can see the number of instruments that are involved in all of the small stuff that has to be kept accounted for. We came out with a large document that was over 100 pages long with 53 recommendations of what to do to avoid retained foreign objects. And obviously it's a multifactorial, including human factors, fatigue, scheduling issues, different sorts of equipment, communication, distractions. We are constantly multitasking as surgeons in the OR. We're taking care of the patient at the table, and we're also managing the patient that's in the ICU. We have pagers in the OR that are constantly going off. Just lots of opportunities. We have residents on 80-hour work week. They can be fatigued and also multitasking. Again, the multitasking, we don't adhere to policies accurately. There's variation in our practice. There are radiology issues that when we have a miscount in the OR that we do a chest x-ray, it's not really a chest x-ray we want, it's a retained foreign object film where you have to see from air to cavity to air, because sometimes the soft tissues are where these retained foreign objects are. We started to involve the lean Kaizen process, and obviously lean Kaizen involves reform and improvement. So each one of multiple areas we developed surgical teams to look at value analysis teams of the surgical equipment that we bring in, instrument set reduction, emergency response, how we communicate when there is an emergency, everything from how we track our specimens, how we start our rooms, get our day going. So on and on and on. We've had multiple teams that we meet, develop a plan, a policy, adhere to it, and carry on. Just to give you an example, when you bring a new piece of equipment into the operating room, these are all of the things that you have to think of, or else it may result in a safety issue. From the training, how you utilize, how you educate the nurses to avoid fire risk, all those sort of things, how biomed is involved. So just tremendous. We developed our own in-house engineering team to help with these process improvement methodologies, and it became very clear as our surgical practice evolved that we needed our own IT that was dedicated to the operating room that would allow us to track safety metrics and utilization and on-time start. So our own IT team has been very helpful for block utilization and scheduling to avoid peaks in the week where people get fatigued and other times in the week when we're underutilized. So in summary, building safe surgical teams is very complex. It's taken us over 12 years to do that. And you have to look at your culture to change your culture, multidisciplinary communication skills, and people who are all levels of education and background and from different parts of the world. But it requires discipline by all parties. There are really no tricks. It's really just hard work around a shared mission and vision. And teams must be flexible and adaptable as new procedures and technologies and regulations come on with time, because our operating rooms of today are going to be different in 2 to 3 years from now. So you have to build the ability to learn and adapt on the fly. Thank you.
Thank you very much.